Okay, so we are now have time to move on to the sessions that I prepared. Okay, is everybody ready? It's very hard to switch now, but let's take a moment because we are going back. We are going to switch back to the CPAP issue and talk about okay, can you see my screen?
Yes.
Okay. So the topic was weaning from CPAP. And before weaning a baby from CPAP, we have to ask ourselves why from the beginning was the baby put on a CPAP. It will help us in further making the right decisions. A term baby, the reasons was meconium aspiration, pneumonia, apneas, maybe asphyxia, apneas due to asphyxia. In a preterm baby, it can be respiratory distress syndrome, apnea of prematurity, other causes of apneas, pneumonia, and sepsis. So we have to know, remember to think about what was the reason the baby was put on the CPAP from the beginning. The second question is that we really know something about the natural history of the disease. So in the term baby, if a baby had pneumonia, then we know that with a good treatment, proper antibiotics, the disease would probably last 4 or 5 days. In meconium aspiration syndrome, it could be, in meconium aspiration syndrome, it can be up to 2 weeks. In asphyxia, it depends on the neurologic examination of the baby. In the preterm baby, if the diagnosis was respiratory distress syndrome, we know that this disease lasts probably for 4 or 5 days, peaking on the 3rd day or 2nd or 3rd day. And this is what the natural course without surfactant. And maybe with without surfactant, the natural course can be a little bit longer. Apneas of prematurity may last until corrected gestational age of 34 weeks. So if the reason of CPAP is apnea and the baby is 30 weeks gestational age, still we do have the risk for apnea at least until 34 weeks. So this is very important that we know that when we start to decide, can this baby be weaned from the ventilator? So we always have to take a look at the baby, and this is a respiratory distress score that we'll give to this baby according to the table that you know so very well. This baby looks sick, he is grunting, he has subcostal retraction and is tachypneic. So we have this respiratory score in our in each time that we examine the baby, and we have the respiratory rate, retraction, cyanosis, air entry, and grunting, and we give the score that we all know. I just wanted to emphasize that if the baby is not getting well according to what the original diagnosis was, we have to look at this table and make sure that we know a few things about the different parameters of this table. So respiratory rate can be high. Maybe the clinical condition is worsening, but also low and high temperature can be giving abnormality in the rate of the respiration. If the baby is in pain, he can breathe fast. So he's showing some signs of discomfort, in maybe an inappropriate positioning or some kind of technical problems. So respiratory rate, if it's not improving, maybe you have to look at this parameters as well. Retraction can be due to still active disease, but also can be due to some technical problems. And this is why we emphasized that we have to look to the prongs, see that they are not blocked, and all the issues related to the CPAP machine itself. Cyanosis, if the baby is not improving with the amount of oxygen that it needs for appropriate saturation, then we have to think about congenital heart disease, and we know the tests that can be done in order to diagnose, maybe listen to the heart for cardiac murmur, maybe do a hyperoxic test, and make a diagnosis of congenital heart disease. If the probe is on the right hand, this might be and have a difference between the left hand, as this can be due to a persistent fetal circulation. So we want to, when we are giving this point on the cyanosis, 1 point or 2 point, we have to see where the probe is situated on the right hand or the left hand, and whether there is any possibility that there is a cyanotic heart disease. Air entry, of course, we have to listen to the air entry and diagnose some kind of complication, but you have to think about the fact that if the position of the head is inappropriate, then the air entry might be poor, and you might give a higher score than it's really needed if the baby is positioned well. Grunting is usually a sign of active disease, but you have to check also other causes of grunting, such as temperature or hypoglycemia, which all can cause grunting. So again, I repeat, if you think that this baby should improve and it doesn't improve, look at the other possibilities that are to be taken in consideration. Now, this table, which all of you probably know very well, we have to understand how we can change the concentration of oxygen by using the amount of oxygen flow and air flow necessary to increase or decrease the amount of oxygen given to a baby. Altogether, you should give 10 liters. This is like what we do in order to give the CPAP to the baby. Whether the saturation is high, we want to change the percent of oxygen by decreasing it. So if we put 5 air and 5 oxygen, the percent of oxygen will be 57. If the baby's saturation is good, high, and we want to decrease the amount of oxygen given to this baby, we will have to increase the amount of air and decrease the amount of oxygen, such as from the 57, let's say we want to move to 50, we'll put air on 6 and oxygen on 4. So this way we will go weaning, going for more air and less oxygen. And if the baby is deteriorating, then we do give more oxygen and less air. When we give 0 oxygen, then the baby will be in room air. If we give 8 oxygen and 0 air, the baby will be in 95% oxygen. So this table gives you the combination of flow of the air and the flow of the oxygen to choose the right amount of oxygen needed for this baby. And we will take some examples of the babies that you have sent me as cases in your MBU. So when you prepare the baby for weaning, you have to make sure that the baby is monitored properly. If you don't have a free oximeter, you have to borrow it from another baby, because you cannot wean a baby if the monitoring is not continuous, because hypoxia or hyperoxia have to be immediately managed as needed. So do wean only when you have enough time to look at the baby and there is experienced personnel around. Make sure that the saturation monitor is properly placed on the hand, and that the device on the baby's head on the CPAP is correct. This is a Hudson probe, but and you are using the RAM cannulas, but the important is that we have all the tubes in place. So remember also that you want to make sure, as I said, when the baby is not improving, that you don't have any technical problems. If the amount of fluid in the CPAP bottle is not enough, if the humidity is not enough, if any of these pipes is disconnected, the baby will not improve, and you will wondering why it's not improving, although he has a disease that now by day 2 should improve. So the signs of improvement for a baby will be the respiratory rate will decrease and the down score will go down. Saturation is good, not borderline, but good, above 95. And the saturation is stable on a low % of oxygen. A baby who is every hour you have to adjust something, it's not a stable baby, so probably is not ready to be weaned. The baby looks usually alert, good looking and vigorous, and he looks comfortable, ready to be weaned off the ventilator. Now, what do we wean first? Do we wean oxygen or do we wean pressure? And for that, we need to understand that what is the diagnosis of the baby? Again, what is the reason for the CPAP? The changes in the FiO2, if you lower the oxygen, the change on the saturation will be immediate. You stand by the bedside of the baby, and you can see that if the baby still needs that amount of oxygen, the saturation will drop immediately. So this is something, when you change oxygen, then the change will be immediate. When you change the pressure, the PEEP, which actually, as we heard in the first lecture of Professor Shani, the PEEP keeps the alveoli open. And when we decrease the PEEP, alveoli can slowly close up. So when you decrease the PEEP of the baby, the change will be not immediate. Sometimes it takes a time to see whether the baby tolerates the decrease of the PEEP or the baby is not tolerating it. So the changes in the pressure have to be made slower than the change in the FiO2, which has to be adjusted immediately. So this is 2 principles. Oxygen should be weaned down as fast as possible by just looking at the baby and waiting a few minutes. Pressure has to be weaned a little bit slower, and again, thinking about what was the original cause of the disease. So the baby, how do we know that the baby is improving? We can wean oxygen to maintain a saturation between 88 and 95, possibly under 50% or lower FiO2 oxygen concentration. And then when we got to this point, we start to wean slowly the pressure by 1 centimeter until we get to 5 centimeters. And then you continue, of course, the monitoring and look at the respiratory score, the saturation and the respiratory rate of the baby. And then after everything is stable, then you can try the baby off the CPAP for a few minutes and see whether still the respiratory score stays stable or the baby starts grunting again or apneic again or tachypneic again. So if the FiO2 is now 30% and the CPAP is 5, infant clinically stable of these settings, and he tolerates the trial of the CPAP for 10 to 15 minutes, then you can consider stopping the CPAP and provide a cannula with oxygen to maintain saturation between 88 and 95%. So remember that taking off baby from CPAP sometimes you will need some oxygen on with a not CPAP, just passive giving oxygen to maintain a saturation which is normal. This is a chart from a real case, and let's just take a look when I get in the morning to this chart. And I'm reading what is the situation of this baby, then I can see that this is the birth weight is 2 kilo, the gestational age is 34 weeks. So it is a preterm baby, not very preterm, on the second day of life. So this baby's respiratory rate was 72, but it's slowly getting down to around the 60, almost normal. And the respiratory score was, in the beginning of the day, was 4 and went slowly down to 3. So this looks good. And I can see that the saturation was very high all the time, 99, 99, 99. The CPAP level given was 7 in the beginning, which was okay to open up the alveoli at the beginning, and then reduced to 5, which is okay, but still left the baby with very high saturation. So as I just said before, saturation can be weaned, the oxygen concentration can be weaned much faster. As you see here, the baby was 70% oxygen at the beginning, and then the whole rest of the day was left with 57, almost 60% oxygen with a saturation of 99. So considering the fact that this is a second-day-old baby with too high saturation, you will want to decrease the oxygen concentration slowly down to 30% and continue weaning. And the CPAP level was already 5. So this baby, we can slowly get to the point when we can wean as a respiratory score was low and hopefully not getting higher even if we reduce the pressures and the FiO2. This is another baby, and what we can see here is that, again, the respiratory score was between 5 and 6. The saturation was at the beginning was low, so this is why the baby was raised to CPAP of 7. After that, the baby remained again with very high saturation. The CPAP level was left on 7, and the FiO2 needed for this baby was 80%. 80%, but still 99 saturation. So we actually don't know here what is the actual need of oxygen of this baby. So we have to go to the table that I just showed before and decide how can we move from the 80% oxygen, which was 2 air and 8 oxygen, 80% OPSA. We want to go down. We want to decrease, go down to 70. So maybe we want 3 and 6. Check the saturation, then go down to 5 to 4, and so on, going this direction until we get to close to room air and see if the baby is still saturating well. So again, in this case, we just can see that it was a high percentage of oxygen. I don't have here the gestational age, as I said before, I really want to know always what is the basic disease that we are treating. So again, I go back to these guidelines of weaning from CPAP. The previous lecture, we talked about what is the worsening signs, and now we talked about improving signs. So improving signs would be O2 requirements and down score, respiratory score are decreasing. Patient has less distress. We reduce first the amount of oxygen given, and then we reduce the CPAP 1 centimeter. It can be every 6 or every 24 hours. It depends on again, what the basic disease is and how often can you look at the baby and make sure that when you decreased the CPAP level, then the FiO2 did not increase suddenly. And then when this is stable and you are ready to stop the CPAP, put the baby on cannula, nasal cannula for oxygen at the 0.5 ml per liter per minute, and see if the baby can keep saturation between 88 and 95. This was again an example sent by you. This is again a small baby, age of 1 day. It's important, and we should always think about the gestational age, so we know what is the possibility that this baby has RDS or other disease. And again, we can see that the oxygen percent of oxygen given was very high, and the saturation were very high, and the respiratory score was actually nice, and actually still probably needing treatment, but not very high. And this was the case presented by you last session, and the question was, if this respiratory score is so low, the baby was saturating 99 to 96, and the CPAP level was 7, does this baby need to continue CPAP? And the answer to this question is, again, as we said, look at the FiO2, it's still 46%. So you should first decrease the FiO2, then decrease the pressure, and see if you still have the same respiratory course and the baby can be stopped giving CPAP. Here, what we can see is this the point where this baby was weaned from the CPAP. We can see that the respiratory score was low, but it was weaned from 57% oxygen and pressure of 6, which is this baby can close his alveoli and actually deteriorate while we do that. So we have to be more careful about dealing with the pressure, and especially in small preterm babies. If the baby is term baby and the surfactant of the baby is enough to keep the alveoli open, then probably it can be weaned faster. So this is for now, and I'm open for question. Hello?
Everybody is around still. It's okay.
Okay.
Thank you very much.
I hope I didn't go too fast, but I really want questions. What is your main debate when you start thinking about weaning a baby?
So usually for our place, the first thing that we try to get right what we call a weaning of chart. So they look at the respiratory rate, and then they look at the saturation. That's our main thing. So immediately they think that the saturation has fallen low, they would even put the baby back on before informing you. So for our place, that's the main thing. We try to see whether when we take you off, your saturation will remain the same, and whether your respiratory rate will still remain under 60. That's for us.
Okay. So nurses would have any question, you can write on the chat.
Alberta is raising her hand. Is it for asking a question?
Yes, please. Good afternoon. Sometimes too, because the machine is 2. Sometimes when the total the CPAP machines are two. If a baby is on CPAP and the total distress score is low, but the baby's saturation is not good, we sometimes also can wean the baby off and then put on oxygen and give the machine to a baby with a higher respiratory distress score.
If I understand correctly, I wanted you to, you have to look again to the lecture I gave in the previous meeting. If you have given already high percent of oxygen and the baby did not improve, you may want to rise a CPAP slowly. And I didn't see in the chart that I reviewed, I never saw higher than 7 CPAP. CPAP can go up to 10. It does have the danger of pneumothorax, but you can raise the CPAP. This is one thing. The other thing is, again, if the baby has a disease which CPAP can help, and this is more the preterm babies which do not have surfactant, much more than an asphyxiated baby who is not breathing, or pulmonary hypertension that it's not helping too much. So before you say that your CPAP is not helping, you try to go on that arm of the algorithm that I was emphasizing. What if the baby is not responding and needs more of a support? Did I answer your question, Alberta?
Yes, please. And I have another question.
Okay,
Yes.
just a minute, Aggie. I think from what I understood, the question of Alberta was if a baby has a good saturation, his saturation is low and the respiratory distress score is 0, if we should keep the baby on CPAP. And you have to remember, it's usually babies that have low saturation. The problem is a pulmonary problem. So if you don't see, if the respiratory distress score is low, you have to look for other reasons for the low saturation. The first one would be that maybe you're not checking well at the right place the saturations. Maybe something is wrong with the probe. Very seldom there are also cardiac problems that can cause low saturation without respiratory distress score. So if the baby is not in distress, you may try to put him off the CPAP and see if he's deteriorating, but I would do it very carefully and very slowly by reducing the pressures before I take off the CPAP. And you had also another question, you said?
Yes, when it comes to term and preterm babies, and given the air and oxygen, you said from this lecture that, hello?
Yes.
Yeah, we can hear you.
Yes, from this lecture that the total is supposed to be 10 liters, both air and oxygen. So for extreme preterms, is it the same or there are modifications for them?
Aggie, can I answer? The 10 liters is important so you will get enough flow to generate the CPAP. What eventually the baby is seeing at the tip of the nose, you know, where the nasal prongs are, depends on the pressure that you put on the CPAP. So you need the 10 liters to get enough flow to get the bubbles. Okay, as long as you get the bubbles, you will get the same pressure. It doesn't matter if it's a term or preterm baby. But what is important, and I don't remember if Aggie said it in the lecture today, that you don't go with premature babies, you don't want to go at very high levels of CPAP. You don't go above 7 or 8. On term babies, you may go up to 10 in severe cases. I hope it answered the question. Agi, do you want to say something else?
Yeah, I just want to go back for a second here. On each of the CPAP machine, you have the table down here. I hope you have it in a higher position that it's easier to look at it. The CPAP is from this area, you know that, and the water has to be enough. And here you have the two buttons. One is for the air and the other one is for the oxygen. Now, the changing the FiO2 is the same with preterm and term. It's just a mixture between the air and the oxygen. So this table, where is the table? The table of this table is the same for preterm and term babies. So whenever the saturation is above 94, you want to give less oxygen and decrease the amount of oxygen concentration by decreasing the flow of the oxygen and increase the air. So you always have the total of 10. And in this corner, you have 28% when you give 8 air and 1 oxygen. And here you have 95%. So this you have to exercise. It doesn't really matter how you make the combination, but make sure you decrease the FiO2. And this is the same with term or preterm babies. And the pressure, as I said, you change here, of course, here. And the response of the baby will be slower, not as fast as the one that you change oxygen. Okay. I hope that in the future we'll have, after we finish this workshop, you will bring real cases from your daily work, and we just do a rounds together and discuss to help us exercise this kind of decision making. When do you wean and how do you wean, and how do you take off the babies, of course, as soon as possible without a deterioration of the critical state. Okay, Ashura, Rita, any more questions? We have in the chat anything?
No, for me.
Okay. Okay, so are we ready to move to the feeding on CPAP?